Disorders of the central and peripheral nervous system significantly increase the risk of functional disturbances in the urinary tract, with symptoms depending on the location, nature, and extent of any lesions. Indeed, 95% of individuals with suprasacral spinal cord injury exhibit symptoms of detrusor overactivity and detrusor sphincter dysynergia, and approximately 75% of multiple sclerosis patients develop lower urinary tract symptoms after disease progression. Here, the 2024 update of the EAU Guidelines on Neurourology provide a comprehensive recommendation for managing neurourological disorders. Firstly, an effective disease evaluation includes patient history, bladder diaries, quality of life assessments, physical and neurological examinations, and diagnostic tests like urodynamics and ultrasonography. In particular, autonomic dysreflexia should be identified early and managed to prevent life-threatening complications. Disease management is highly patient-dependent, hence should be tailored to patient needs. Looking at the treatment recommendations regarding assisted bladder emptying, Credé and Valsalva maneuvers are useful, however are generally discouraged and less deemed safe according to urodynamic studies. Regarding drug treatment, the use of antimuscarinic therapy as first-line medical treatment for neurogenic detrusor overactivity is recommended, with intravesical administration a possibility if systemic side effects are important. Where necessary, it is also important to prescribe alpha blockers to decrease bladder outlet resistance and reduce the risk of autonomic dysreflexia. Regarding catheterization, the use of intermittent catheterization is the standard of treatment for patients with elevated postvoidal residue, and it is important to avoid indwelling transurethral and suprapubic catheters whenever possible to decrease the infection risk. Regarding minimally invasive procedures, bladder wall botulinum toxic A injection provides reversible chemical denervation for approximately 9 months, with more than 0.5% of patients continuing treatment long term. Regarding surgical treatment, urethral slings, particularly for self-catheterizing women, provide lasting benefits, and artificial urinary sphincters are durable and successful, especially in men with neurogenic stress urinary incontinence, however are associated with higher complication and reoperation rates. Moreover, intestinal bladder augmentation is also an option for enhancing compliance and reducing neurogenic detrusor overactivity, resulting in benefits for long-term renal function and quality of life in a certain subset of patients. Regarding urinary tract infections, some recommendations include not using dipstick urinalysis to screen for UTIs in neurourological patients, to not screen or treat asymptomatic bacteriuria, and in patients with recurrent UTI, it is important to avoid long-term antibiotic therapy and to optimize treatment of neurourological symptoms and to remove foreign bodies such as stones and indwelling catheters from the urinary tract. Finally, regarding sexual function and fertility, prescription of oral phosphodiesterase type 5 inhibitors are the first-line medical treatment for neurogenic erectile dysfunction, with intracavernosous injections of vasoactive drugs as second-line treatment. And it is important to take a multidisciplinary approach tailored to the individual patient's needs and preferences for the management of fertility, pregnancy, and delivery in women with neurological diseases. To conclude, these are some of the updated EAU guidelines which provide a framework for effective management of neurourological disorders, emphasizing early diagnosis, individualized treatment plans, and multidisciplinary care is essential for improving patient outcomes and maintaining a good quality of life.